Yeah, this is a great discussion. And so we will be discussing relapses later, because I will say after the casting techniques issues for correction, then the next thing is using the brace, and we have a little bit of discussion now before, and then the other one is how you treat relapses. But in between, one of the issues that you are going to see is what it was called the atypical complex Clubfoot, and Monica actually put a lot of pictures of this kind of foot, as you can see here. And I think that it's critical to understand, the definition and the difference between those two terms, the pathology, why this happened, and how do you manage these patients, and what are the outcomes of typical complex Clubfoot. And I think it's important to understand that atypical is the definition of a Clubfoot that has specific characteristics that we will discuss here in a second, but is before any treatment. Okay, the feet has some characteristics that make it different from the typical Clubfoot with cavus, varus, and so forth. Okay, so that is an atypical Clubfoot. In the Clubfoot community, some people use the term atypical for neurological Clubfoot or associated with syndromes and so forth. Those are neurological or associated with syndromes. But there's a Clubfoot that is different, and it's idiopathic, and it has no syndromes, and it's just the characteristics of the foot, and that is the atypical. Complex is referred to the Clubfoot that happen because of problems with casting. And it can be just a typical Clubfoot that has problem with casting, or sometimes can be atypical that is not being recognized, and you have problem with casting, you end up in a complex Clubfoot. Now here in this slide, you can see a kid that is before treatment, and he has a Clubfoot, and you can see here, doesn't look like it's really bad. But there's a few things that call the attention. Number one, he has a little bit of hyperextension of the big toe. And the other thing he has curly toes here. And you can see here, notice that it has cavus, but the crease goes all the way to the lateral border. Okay? And then, if you look at underneath, you see that the crease goes all the way laterally in both sides. There's hyperextension of the toes. And if you look at from the side, you have also cavus on the lateral side. It's not just in the medial side, it's on the lateral side. So you have a crease all the way through because all the metatarsals are down. Okay, that is an atypical Clubfoot. Now, if you treat this foot like a normal Clubfoot, the problem is when you are doing abduction, because all the metatarsals are down, then you are going to break the midfoot. It's not going to make, you have to elevate first and then bring it out. And if you don't recognize this deformity, then you have difficulties with the casting. So on the lateral side, you can see here that you have usually severe equinus. You have a deep posterior crease, but the heel is still preserved. It's not flat. It's not like complex. When you have problem with the casting, the heel is very, very flat. You have a deep crease both medially and laterally, and there's plantar flexion of the fifth metatarsal is the first metatarsal, and then you have a little bit of hyperextension of the big toe. When you look at from posteriorly, you can see the varus. Usually the abductors in some of these feet is not too much, but you can see here the crease all the way down, okay, and then the crease here in the back. But then you see the heel still has a nice shape. So in these cases, I mean, like in any case, you have to mold that heel very well. And if you don't mold it, then these feet are very easy to come out of the cast. And that is one of the problems. And then you get swelling, and then you get into what is called complex Clubfoot. So the management for these ones is that you have to stretch all the metatarsals, not just the first one, elevation. You have to stretch also the fifth one, because all the metatarsals are down. And this is from Shafiq Pirani, you can see before. And just with one cast, when you do it this way, you can start getting the correction of the cavus. And you look at from the side, you get some of the correction of the adductors, and then the heel, gets nice contour, and then you start seeing that the crease start fading. and the foot start getting straight, and this is just one cast. So these are not difficult feet to be corrected. It's just you have to identify, and you have to tailor the casting to the deformity. You can see here how much equinus, and here we just, if you do a good casting, molding behind the heel, and then you stretch the plantar aspect, you can see that the cables also start getting corrected, and this is just one cast. So the key here is to identify these cases early, and then if you see that that's happening, you have to tailor the correction to what the foot is asking you to do. You have to listen, Dr. Ponseri used to say, you listen to the foot. He's going to tell you what to do with for correction. So that is an atypical clubfoot. Now, what we call complex clubfoot is the one that comes after casting. And many people call this resistant clubfoot because the experience is that after 3, 4, or 5 casts, the casts start coming off. Then you have problem of swelling and skin issues. You have hyperextension of the big toe. Then you can see here the plantar crease. And atypical and complex share that commonality. They share the plantar crease, they share the metatarsal that is in hyperextension, and they share the posterior crease. The problem with the complex is that, in general, the foot is coming out of the cast, and then it creates edema and skin problems, and then a very rigid equinus, because when the foot comes out of the cast, it puts pressure in the back. And these feet were the ones who before, and still people are doing surgery. This is from Miro Lastijo from Bulgaria, some cases that he shared. You can see here, you know, the big toe is normal, actually pretty long, and there's no crease all the way. It's just a regular clubfoot. And this is what happened after 7 casts. You know, the last 3 casts coming out, you have the skin problems, short first metatarsal, crease all the way to the other side, very flat heel with the crease all the way to the lateral side. So this is a complex clubfoot. Another case, very long toe, and I point this out because they don't come and you see the crease doesn't go all the way, just, you know, a regular foot. But if you have problem with casting, after 7 casts and 2 or 3 coming out, this is kind of the picture that you want to see. And this is not the foot, this is the casting, okay? And you can see that it's very short, the crease, this is completely flat, very deep crease, the equinus is almost 90 degrees. So these feet are, and then they are very tender. You touch the skin and the kid cries crazy. It's like an RSD kind of like type of situation, I think. This is a Mark Sinclair case that he gave to us. Same thing, you can see here the big toe is long, and yeah, it's a clubfoot. The crease is only up to here, so this is a normal clubfoot, but if somebody has problem with casting, you get exactly the same reaction. The skin problems, big toe short, the crease, as Monica was showing, going to the lateral side. I mean, the foot is like this, so there's more skin. If you have a crease on the lateral side, it's because something is moving this way. And if you take an X-ray, this is what happened. Okay, so if you see a crease on the lateral side, it's because all the metatarsals are shifted. And you have to bring them back, and you have to start working in the dorsiflexion. Okay? This is one that is a little bit further in evolution, 4 months, a lot of Ponseri casting, and that is one of the issues. They did a tenotomy, but still the foot is not fully corrected. And you can see how, you know, from here to here, how short the foot looks like, because it's like this. When you stretch them, usually it gets almost to the same size, but in this stage, and if you palpate the calcaneus is actually here, and the heel is very, very soft. Why this happened is most likely related to the Windslash mechanism. When you tied up the plantar fascia, the first metatarsal goes up. And if you tied up the plantar fascia and the Achilles tendon, this is the deformity is going to happen. And this is, I think, what happened with complex clubfoot. For some reason, and maybe not typical, what happened is that this soft tissue muscle deformity, abnormality, which is Clubfoot, is not in the foot, it's actually in the muscles and the soft tissues. It actually involves also the plantar fascia more, not just for the first metatarsal, but for all the metatarsals. And when you have that, then the normal mechanism makes this deformity to happen. So in order to correct it, then what you have to do is to stretch that plantar fascia and then stretch the heel cord. The paper was published in 2005, and it was 75 Clubfeet that were complex, the same kind of proportions for male and females, and most of the patients have casting, and 14 of them had tenotomy. And this was the first 2-year follow-up. They presented to our clinic all through the first year of life, but mostly kind of in the first 3 or 4 after a problem with casting. If you are good on your casting technique, you can correct most of them with 4 or 5 casts. Occasionally, it takes you a couple more. But your casting technique has to be superb. If not, and you don't have enough experience, because in one single practice, usually you see one of these once a year or so, then I think it would be important here for the country that somebody has more experience to accumulate, because otherwise you are going to be doing a lot of surgeries. Let's see. The recurrence is 14% up to 2 years of age, and I will show you what happened in the longer time. And sometimes you need to do another tenotomy, and there were 2 patients that required surgery for a posterior release. And these were the early patients, and they were done in another institution, not in Iowa. We have not done any surgeries for these feet. The complications are mostly related with casting problems. And then you have to be careful when you are stretching not to go overboard and then create a rocker bone deformity. One thing is to stretch the plantar fascia to get a normal arch. Another one is to go too much. And the other thing that is still a problem and a question is how much force you apply and how forceful you do this correction, because what happens is that you can get a flat talus, as Monica explained, when you don't get the correction precisely. So how do you do, in these cases, your casting technique? Well, you have to correct not just the cables on the first ray, but all the metatarsals. So you have to correct what's called the plantaris. You don't want to go in too much abduction because your metatarsals are shifted most of the time. So you want to keep it in about 20 degrees or so. Because the cast comes off very easy, you have to bend the knee a lot. Otherwise, it will keep coming up. And what you do is also go as high as you can with your casting up to the groin. And most of the time, these kids are very chubby. You know, they have the foot is very small and, you know, like that, and then they have big thighs. So when you put the cast, you have to put a little bit of pressure, and you have to mold your thigh to be a tube instead of being a cone, because that helps you to control that thigh, and so the cast doesn't come out. And you have to be very careful when you do your casting not to create a tibia, a bow tibia, like Monica showed you in one of the cases. So this is the way you do the manipulation and the stretching. You see, you stretch the whole forefoot in relations with the hind foot. And when you do the casting, somebody's putting pressure, so you can do a little bit of, no dorsiflexion, correction of the quinus, and then correction of the plantar fascia mostly. In this case, you don't need to put your thumb on the head of the talus because you are stretching the midfoot. You are not going into abduction, okay? And then it's critical that you mold very, very well behind the lateral, behind the heel to create that shape so the heel gets that rounded shape and it doesn't get flat again, okay? And this is very, very critical, otherwise the cast comes off. And this is what happened when the cast comes off, then you get a bow tibia, or did you put the cast without molding and maintaining the tibia straight, like here, and then going all the way up and bending the knee as much as you can. And you can about 120 sometimes, depending on how chubby the kid is, but you have to be very careful in the back here not to put your cotton just in the popliteal fossa, because then you are going to get a sore in the popliteal fossa. And if you get a sore in the popliteal fossa, it will be scarred for life. I have a couple cases that they had a sore, and it stays there forever. So what results can you expect from this technique? This is the case that I showed you before. After 4 more casts and a tenotomy, this is at 7 months of age. You can see that the foot start showing, signs of a nice correction. You can see that still there's a little bit of crease, what that means that the toes still have a little bit of abduction, and you can see that the alignment here is relatively normal. You can see here that sometimes is deceiving because the fat pad is very prominent in these cases. And if you go by the fat pad and not by the feeling of the calcaneus, you can maybe force the foot or do the tenotomy too early, which I have seen happening sometimes. This is the same patients at 40 months of age, and you can see here that the foot start turning pretty much normal, and then the evolution usually is pretty normal. This is the other case that I show you. 4 casts later and tenotomy. You mold it very well, and then you make this part like a triangle. Then you can squeeze all the soft tissues, and then your heel goes into valgus. This is the patient at 1 year of age with good alignment. This is the patient at 4 years of age. And see, there's still a little bit of cavus sometimes. Sometimes it's very hard to get that cavus completely resolved, and it might stay for quite a bit of time, but functionally they do okay. This is a Mark Sinclair case that he received from another institution, and you can see here how after the tenotomy the foot has about 10 degrees of dorsiflexion, and then normal valgus. You see the heel, the crease here is a little bit less prominent, and this is the patient at the age of 4 or 3 or 4, 12 months of age actually, sorry. And then you get a little bit more dorsiflexion. The other thing you're going to see on these cases is that when you do the tenotomy, don't expect to have 20 degrees. It's going to be 10 because they are stiff in the back. So when you do your casting, if you don't mold it very well and you keep those 10 degrees and then they come back like this, then when you remove the cast of the tenotomy, it's 0 or maybe 2 below, you put it in the brace and then it starts coming out. And then you get the, the sore in the back. And one trick for these cases, if you have that situation, is take the bend on the bar and make it straight and put the boots at 30, not 60. Okay, and if you don't have those 10 degrees of dorsiflexion, because what happened is the foot is not coming out that much, and then over 3 months the kids start kicking, and then you get 10 degrees or so of dorsiflexion by the kid kicking, and then when it normalizes, then you can bend the bar and then you can go to 60. And usually it takes about 4 to 6 months. So what happened with these patients for midterm? And so we evaluate these same patients with a resident, and the paper is under review. So we don't know what happened. 2 years, there was only 14% relapses, and the patients were doing relatively well. But what happened with these feet that are very hard, to correct at the beginning? And so we did extensive questionnaire, physical examination, and X-rays. You can see one of the cases how much of abduction of the metatarsals are sometimes if you are not careful. So 54 patients, which is that group, and now they were 4 to 10 years of age. So 28 participated. They came to the clinic and with 48 Clubfeet. Most of them were bilateral. We did an extensive X-ray evaluation, as you can imagine, and we also look at the Tailor dome, and actually with bioengineering, they developed a program to measure this electronically. The follow-up was 6 years, from 4 to 10. 23 of the patients were treated in an outside hospital, and they came because of the complexity of the Clubfoot. The average number of casts was 4.7, 1 to 14. None of the patients in this group required a posterior release or posterior medial release. But one thing that we found is that by the age of 4 to 10, usually about 6 average, is that 68% had a relapse. Even using the brace, there was no difference between compliance and non-compliant patients. So these feet, when they go through this process of complexity, although they might be normal, it might change the biology of those muscles and make it more fibrotic because of this RSD kind of thing, so that everything gets a little tighter. And then over time, that doesn't get better. And I think that is what happened with this complex Clubfeet. When you look at the POTSI and the ESI scores, there was no difference between the typical and complex Clubfeet, and satisfaction was about pretty much the same. Dorsiflexion average, it was about 10 degrees, and still a few patients had a little bit of cavus, okay? Now, when you compare the unilateral complex with the normal side in the patient with only one side, the foot was about 1.5 shorter, so 1 or 2 sizes smaller. The Achilles tendon was longer, and the circumference was 1.3. So we measured that clinically. So these muscles are small, and you palpate the Achilles tendon, and it's thicker, and it goes all the way up, and there's just a little bit of muscle on the top instead of 2/3 of your thigh, of your calf muscles. If you look at your calf muscle, right here, see there's 2/3 of calf muscle and 1/3 of Achilles. In this case, it's 2/3 of Achilles and then just a little bit of muscle on the top. So somehow the muscle may be atrophy or gets affected by this process of swelling and so forth. So, so it affects the development of this. And the other finding is that 25 have flat talar dome, 50% was oval, roundish, and only 25% was normal, round. And the problem when you have a flat talar dome is that there's not going to be dorsiflexion for the rest of the life of that patient because it's flat. I mean, it's like a little bit like this, 5 degrees, and then you're done. So when you do this correction, first, if you get in trouble with the casting and you are getting into this complex situation, don't keep trying. Don't try to do the tenotomy early and see if I can lift it up and see what happens. You are crushing the talus really bad. And second, all these soft tissue injuries that you are created by this problem with the swelling is going to make the tissues much stiffer, which is going to result in less growth, which is going to increase the relapses even with the patients using the braces faithfully. So you start seeing that a patient start developing these characteristics of complex Clubfoot, which means they start having a little bit of swelling edema, the big toe start going up a little bit, and he kind of sleeps one day with a cast. You know that you are going to have a problem. Be very careful. And if you feel that it's not going right, it's better to wait for 2 or 3 weeks and let it subside than to trying to keep casting and doing the tenotomy because you are going to make it really, really bad. And 60% of the patients have a talar dome that it was on the computer program, not round completely. So the outcome of these patients is okay, but you have to expect that 68%, I mean, this is compared with 11% in typicals, it's very, very high relapse rate, even with good bracing, although the patient satisfaction and function still is good. There's a residual cavus, so these kids have some difficulties finding shoes because they have too much cavus and the shoes don't fit properly. And talar flattening is relatively common, and this can be prevented by doing good casting and tenotomies at the appropriate time. And all of them had, the majority of them had a very long and tight Achilles tendon that make it more difficult to grow, and that's why I think the relapse rate is very high. So the take-home message is, and I want to emphasize, and your experience, the casting technique is extremely important. And in my experience, I have no case that I couldn't get 60 degrees of abduction. with just the casting, and then you do your tenotomy. Now, I want to ask you, and we will discuss this afternoon about the casting, what is the size of the talar head in a newborn baby, or 1 month old, whatever? What do you think is the size of the talar head on your experience? The diameter? It's about 5 to 7 millimeters. What is the surface of your thumb tip? It's about 1.5 to 2 centimeters. The calcaneus is 1 millimeter below the talar head in a newborn baby. So what happened for most people, and that is what Monica is trying to explain, is that, yes, you put your thumb on the talar head, but this part of the thumb is blocking your calcaneus. And unless you precisely put the tip of your finger, of your thumb, on the talar head, otherwise you are locking yourself. And I can guarantee you that that is going to happen. So this afternoon when we do the practice, I will show you, and once you learn this, you are going to realize that, oh yeah, I'm doing that, and that's why you are not getting the abduction. And that is a technical issue that I see, you are right that you have your thumb on the talar head, but you have the thumb in the talar head and everything around because your thumb is 3 times bigger than the talar head. And unless you do it with that precision, then that is why you, in the cases that are a little stiffer, because they, half of them are okay, but the ones that are stiffer, then they don't come around. And it's all in the technique. It's not in the foot. If we can correct arthrogryposis, which are the stiffest that you can even get, and get 98% of them corrected, idiopathic clubfoot is not a problem. So is the casting technique the key for correction, okay? And I hope that this afternoon we can all, see the points of how to handle this, because it's going to be critical for you to learn that, and then you will go back to your clinics and you will realize that, yes, is the casting technique the main problem, okay? Questions?